The next question from the panel last week had to do with what were called institutional barriers. I have to even read the question because it was more technical. And the question was this: how should systems of care and or payment systems be redesigned in order to accentuate the importance of the family in continuing care? So that was a mouthful. And I'd like to share some of the things that I read in preparation. I didn't get a chance to speak these last week, but I did do some a little bit of research background on this. And it might be helpful just to share the information. I read a few articles on the Affordable Care Act, and particularly how it relates to addiction treatment. And these are some of the points that came up again and again, and I think this is all getting itself sorted out because this is all still really new in terms of implementation. One piece that comes up generally in insurance, and it seems like it's perpetuated itself even with so-called Obamacare or the Affordable Care Act, is that insurance typically will ignore treatment of addiction beyond just the most acute phase, which is typically the detoxification phase. Is even in the face of almost all research that's been done on the phenomenon of addiction, much less what treatment seems to be effective, would support a longer term view. In fact, it's oftentimes compared to other chronic illnesses like asthma, cardiac conditions, diabetes, is that these are chronic conditions that typically relapse is built right into the diagnosis. Addiction almost fits better into that model, and yet insurance companies, while they might they do reimburse, for example, let's say diabetes treatment, would be loath or resistant, make it very complicated to be reimbursed for treatment beyond just the most acute detox phase, and that can be just for a few days of treatment. Anybody that works in the addiction treatment industry would recognize the short-sightedness of that, or just how it's so disconnected from what has proven to be effective in research. It's an interesting piece here. I just read this in the National Institute of Drug Abuse, is that treatment for alcohol and drug abuse is effective. It was a meta-analysis of tons of different studies that have been done. It's effective, but what that means is it's effective if it's implemented and if the terms are complied with, and it means it's a chronic long-term treatment. You wouldn't say that a single treatment of somebody with asthma is sufficient to treat their condition if it's a chronic respiratory problem, is it requires ongoing treatment. Ongoing treatment has proved to be effective in terms of preventing relapse, sustaining sobriety, and all that goes with that. It's just that insurance companies, understandably, are not cooperating with that plan. They want to reduce their expenses, I assume. And this was highlighted for me a week before last. I got the chance to sit with a local psychiatrist who's the CEO of the largest inpatient substance abuse treatment center here in Orange County, Dr. Daniel Hedrick. And he said that in his experience, he's worked in the field of substance abuse treatment for over 30 years, is that he just said, as a rule of thumb, he tells addicts and their families that it takes 90 days for the brain to reset itself to even begin to engage in what would look like normal outpatient treatment. So some form of the things that we mentioned, psychotherapy, addressing personal lifestyle choices like beginning to develop some kind of nutritional and exercise regimens, for medication to begin to take effect, is that for a brain that's been bathed, the example he gave, he treats a lot of opiate addicts. It turns out that Orange County is second in the nation in terms of prevalence of opiate addiction, which is a startling statistic. And so a lot of what he treats in his hospital setting are opiate addictions, is that you don't really have, in another setting, I worked with a psychiatrist who called it, you don't have the birthday brain. You don't have the brain back to its natural baseline state for 90 days, give or take, and probably give. There's probably, in many cases, I've read up to 6 months to a year sometimes to get the emotional apparatus. As a psychologist, looking at the emotional balance for it to reestablish, to begin to develop some kind of equilibrium, can take 6 months or a year, which is bracing. But if that's the case, then we need a more enlightened policy in terms of insurance coverage. The irony of this is that with recent legislation in the last 5 to 10 years, there's for the first time parity, and that is that insurance companies are legally required to reimburse for drug treatment or alcohol treatment as they would for any other medical illness, as for a broken leg or any other thing you can imagine, various surgeries and so on. But that, I understand from the readings I've done, those laws are honored more in the breach than the observance. That is, that they're systematically ignored by, it sounds like the powers that be, including insurance companies. So there's more work that needs to be done there. I think I've already mentioned this, but that insurance companies in their literature are remiss and or notoriously ambiguous about discussing relapse as part of addiction. It's very much this kind of bipolar thing. You're either addicted or you're cured, and that as with any other chronic illness, there's always, like around diabetes, you're always adjusting insulin levels and having to follow the patient's treatment, and it ebbs and flows. It's no different with addiction, and yet if you only have this kind of bifurcated view of treatment, you can see how that middle zone of really continuing care is ignored in terms of financial reimbursement. There's another loophole that I came across. Again, all this has to do with payment systems and systems of care, is that as promising in many ways as the Affordable Care Act is, there are certain loopholes, especially when it comes to treating addiction, that small businesses may be exempt. Medicare and Medi-Cal are exempt from reimbursing for addiction treatment. And so a smaller business can legally appeal to this exemption. And so that, on paper, it looks like it's a good thing. Now it's required that addiction be treated and that it be reimbursed by insurance. But there are all kinds of loopholes out there right now that really limit its applicability. So this is a whole area for massive, I think, examination and growth, and it's going to be a piece of work to get this to move politically, I think. Let me mention just as a backdrop, in terms of my work in psychology these years, the diagnostic manual in psychiatry and used by psychologists and other mental health practitioners is the infamous DSM, the Diagnostic and Statistical Manual. It's just come out this year in its 5th edition. And that manual has been written in the United States of America. The American Psychiatric Association publishes it. We are the most individualistic culture on the planet by all estimation. Anybody that ever read, sociologists, cultural anthropologists, we're it, as compared to almost any other culture that is more communal, family-oriented, community-based. We're the most individualistic culture on the planet. This flies in the face of psychological research that I referred earlier. Interpersonal neurobiology has introduced the idea that we don't exist in isolation, but rather the term is that we co-regulate. This is why, by the way, working with families is absolutely crucial to effective treatment of addiction, is that we co-regulate one another. In other words, that we affect each other's emotional lives. All of us know that common sense-wise, but it's now been shown at a brain level. We can hook up our respective brains to brain scans and move into an interaction, and let's say that we move into an argument, and that's going to manifest in functional changes immediately in the brain, and if that's chronic, it will eventually manifest as structural changes, and so that's a way of understanding how we co-regulate. So we've got this kind of, to my mind, archaic system then of diagnosis. I don't know a solution to this, but I at least have to name the problem, which is that all of our diagnoses are individualized. And so you go to the DSM, and every diagnosis is a diagnosis, from a family systems perspective, it's a diagnosis in a vacuum. And so I've got borderline personality disorder, or I've got major depressive disorder, or I've got, substance use disorder with whatever substance, alcohol or cocaine. And it operates as if that's in isolation. And I understand in some ways why that's necessary, at least for simplicity's sake. But it's only the tip of the iceberg, as I understand it, because as soon as you introduce a family systems or a more communal orientation, which is alien to our culture, as soon as you introduce a more systemic approach, you realize what's missing in a diagnosis like that is all the other constituent components that make that diagnosis happen. I taught for years a course on borderline personality disorder, and one of my favorite authors in the field, Robert Stolorow, had this question that cut right to the chase. He would say he was very uncomfortable naming somebody as having borderline personality disorder. He preferred to call it borderline personality states, that is, that they're discrete states of mind. We all know them personally, depending on however we're wired and whatever circumstances we've been in. And his formula was borderline in the presence of whom? And I've remembered that over the years, is that diagnostic nomenclatures like the DSM don't afford for that kind of level of analysis of looking at a systemic or a contextual view. And so you might say, addicted in the presence of whom? Or addicted in the presence of what? If I'm impoverished, if I'm an ethnic minority, if I've got other variables, if I'm a male versus a female, there are certain statistical givens that predict that I will be much more likely to be addicted to a range of substances or a given substance. And so addicted in the presence of what society, what culture, what financial status, what gender, what family. So that's a limitation, and again, I want to name that as a problem, and I'm not sure exactly what the solution is, but there's a box that we get into. It's a circularity, is that we use individualized diagnoses, and then we reimburse based on the DSM. So the insurance reimbursement is based on the individualized diagnostic scheme, and there are problems with both, and how to have at least a critical outsider stance towards that could be helpful. So one of the things we encourage in our addiction studies programs here, I know because I've helped write the curriculum, is asking questions like this. So it's included as assignments to look at what are the strengths of our systems of care here in the U.S., and there are many, and then what are the limitations culturally, economically, politically, et cetera. Just to be able to take that perspective, I think is important. I really do think of people in mental health professionals need to be activists, or at the very least advocates for their clients, because most clients aren't asking these questions. I'm also here at Cal Southern thinking of a conversation I have not infrequently with one of my colleagues who's the director of our criminal justices program, Tommy Tucson, who's a retired police officer. And Tommy worked in the penal system, the law enforcement system here in California for years and years. My own father was a psychiatrist who worked in the state prison system in California as well. And so I have both of these sets of conversations, one of them over my lifetime and the other in more recent years at Cal Southern, is that in many ways the problem with our criminal justice system is, in Tommy's words, is about reentry. I think that's the technical term that's used in criminal justice. How do you get somebody to integrate back into society if they've served their time? Let's say they've gone away to state prison for 5 years for a drug-related offense. Well, I'm thinking of that. 80% of our prison population in the U.S. are there because of drug-related offenses. That means they were either high when they committed a crime, were selling drugs, or procuring drugs, were found with drugs in hand. That's 80% of our population. We incarcerate those around drugs, and I think you can imagine my opinion about that. I don't think there's an easy solution to that, because I don't advocate people being out on the streets that are deranged and violent. And drugs do crazy things in terms of commandeering our moral judgment and our impulse control. Not about soft pedaling that at all. Yet we do have a problem, is that we incarcerate in mass form our drug addicts. They get out of prison, and what can be done to help them reintegrate? And from a criminal justice perspective, I think there's another issue around systems of care. My training in psychology was one course in graduate school in substance abuse, and I think it's getting better. I know that it's better here at Cal Southern because we have multiple requirements around training in the whole range of addictions, behavioral and substance-related addictions. But how to address this part, which is when somebody comes out of prison, they've got legal problems. How do they get a job? How do they salvage a life of any kind? How do they have transportation? The most basic things. And to the extent that those are ignored, both in criminal justice and I'll say in mental health, are we shocked that, I've just read the percentage a week or two ago from the U.S. Department of Justice or something, and I can't remember it well. The recidivism rate is just stunning. It was like 60% of people that are released from prison return within 3 years, or it's something of that ilk. and in my conversations with Tommy, my conversations with my father, it's like, well, what do you expect? People get out, they have such limited options available to them, and the one thing that they know is crime and or prison. So I feel like that's got to be addressed. And I think that's included in being addressed in our addiction studies program. We're right now cooperating. Tommy and I are working on creating, as an aspect of all of our curriculum, addressing reentry phase for those that have been in treatment or in prison, because we had a conversation earlier. Very few people come into treatment until they've hit bottom in some way or another, and oftentimes that involves having committed crimes of theft or DUIs, drunk driving, etc., where the 12-step programs call them wreckage from the past. How do you help people deal with that, and isn't that something that therapists should be providing? I believe so. Finally, in addressing systems of care and having the families be involved is my own work these last few years on addressing shame and stigma, is that these are barriers to treatment, not just within families and within individuals, but also culturally. And so one of the things I want to say is I believe that mental health providers that, I'm going to state it more strongly, I think mental health providers need to be educators. And so I think that it's not enough to see 20 or 30 clients a week and consider your job well done, is that there needs to be really getting this information out there in churches. I'm going to come to that in my final segment in just a second. In churches, in schools, all ranges of education, from kindergarten all the way through, in civic organizations, we've got a systemic problem culturally around wanting to morally judge addicts, as well as pick them out individually, pull them out of the context of their families and out of our culture, in some way to educate that addiction is a systemic disease. It's a brain disease, it's a systemic disease. It's a lot of other things than the old fallback position, which is it's a moral failure. I find that position is very limiting and really not helpful in helping people move towards recovery. I think that's, I want to say one last thing. It's a little bit of bad news to go off on. I just met a couple weeks ago with somebody that's been involved in a local city, the city of Newport Beach, and it's also happening in Costa Mesa right now. These are both Orange County cities. And shame on them, and I also kind of understand why it's going on. They've got a lot of funding right now. It's actually going to the state Supreme Court to outlaw treatment facilities of addiction in these two cities. And I understand that. You just think, if my neighbor is a rehab, or a rehab is going in, I'm going to have second thoughts about that. But is there any way that we can have some kind of dialogue? This has to do, again, with kind of systems of care. So cities outlaw treatment facilities. We're not going to have any sober living facilities in our town because we don't like how that goes. And I think that education would be part of that, is to understand what goes on in these treatment facilities, what is addiction. There really is this kind of old puritanical idea, I think, that if somebody's an addict, that they're somebody to stay clear from, and there certainly are addicts that's the case. My sense of it, this came from the conference in Boulder, is that addiction oftentimes takes out the best and the brightest, as well as the losers and the lowlifes. That's typically the stereotype about addiction. But you have a lot of really talented people, and any of us that read the newspapers every day can see really gifted individuals being taken out by addiction. It's the grand leveler. And so if we start outlawing treatment of addiction in various communities because it's inconvenient or unsavory, while I can understand that as a human being, I think we need more education and some form of kind of moral enlightenment around this, because I think that's a one-way road to unhelpfulness. That's all.